We continue with our Health Friday conversation now, and we are joined by two gentlemen in the studio. Dr. Abdi Mohamed is the chairman of the Kenya Association of Private Hospitals. Geoffrey Mwangi is an expert on health financing, and he's the former CEO of NHIF. Good morning, Dr. Good morning, Jeff.
Good morning.
Good morning.
Karibuni sana to Kenya's biggest conversation.
Thank you.
That's the hot seat of the Situation Room. You're here. Dr. we've talked to you many times, but virtually.
Yes.
So here you are, in the room.
And truly, it's a hot seat.
Yeah. All right, but hata joto.
Bado hata...
You're already feeling, surely.
Because health is usually hot.
Yeah, that's true. That's indeed very true. Geoffrey as well, karibu sana.
Thank you very much.
Good to have you here. With all the knowledge and experience you've had working for the NHIF, karibu, and understanding health financing. To welcome you both to the conversation, CT has the day's proverb.
Yes.
This week's proverbs are from Zanzibar. They are in Kiswahili. So the first thing that we want you to do is to directly translate what you hear in Kiswahili into English and tell us. And then you'll interpret the proverb.
Yes, makali ya jicho yashinda wembe.
Makali ya jicho yashinda wembe. Daktari?
The sharpness of the eye is greater than the razor.
Mm-hmm.
Direct translation, good.
Jeff, the same?
Yeah, the sharpness of the eye is sharper than the razor. Or is more, what do you use? The other word of more sharper is... There should be a better English word to translate it.
For sharper.
Yes.
There should be a sharper word.
Yeah.
What's your interpretation of it, Jeff? What do you think the proverb is telling us?
Well, is that the eye is, if you are to perform surgery, the eye would cut deeper than the razor. That in normal life, the eye has a bigger view, has a bigger vision, can transact somebody directly.
Mm-hmm.
Since it's from a coastal town, I would say it's more to do with people's eyes are more powerful than any other sharper object that you can think of.
So, Mwalimu?
As always, I'm sure you will say it's correct.
Well, it is. You're absolutely right. You see, when you ask for someone's opinion, how can they possibly be wrong? And they have given you their opinion. It isn't possible to be wrong.
True.
But I'm sure I've come across people who tell you, the person looked at me with a bad eye.
True.
So is it there was something wrong with their eyes, or is it that the look?
Unaniangaliaje?
Yes, exactly. So what does the look portray? Because there is no look if there are no eyes.
The eyes can penetrate into the soul.
Yes. The eyes seem to speak a language of their own.
They can send a message.
Yeah, they send
a strong one.
That is, that's it.
A very strong message.
Very strong. Just one look. If it's something that people remember of their mothers, many mothers didn't need to tell you anything; they just need to look at you.
Thus.
One look, and you've gotten the message, and
you start bleeding.
and you know exactly what is required of you. One look.
True. True.
Makali ya jicho yashinda wembe.
Yes.
All right. So last week, Friday, President William Ruto launched the Universal Health Coverage Program countrywide. This is after he had assented to the new bills for the health sector that are paving way for this. After that, he said, now we're going to have regulations that will come into place so that we then bring these particular laws into life and UHC will be fully operational. As we stand here today, as we sit here today, Dr.
Yes.
As the chair of the Private Hospitals Association, do we have UHC in the country today?
First of all, we need to keep in mind on one thing.
Yes.
UHC is never a destination. It's always a journey. And there's no country that can say we are fully, we have reached the end of healthcare delivery. But I want to go back June 2022, on 27th. If you recall very well, UDA, the then presidential candidate, had a health forum. We were invited as stakeholders during that time. We gave memorandum, and we also went and presented verbally what were the things that we wanted to do, to be done in the country. A few weeks later, there was a manifesto that was launched. If you look at that manifesto, and you look at the 4 bills, you will find exactly what was in that manifesto. So it says the Kenya Kwanza government will deliver UHC on 3 platforms, on 3 pillars. So the first pillar, it says we will deliver tax-funded primary health care, which will focus on promotive, preventive, diagnostic, and treatment at the lower levels. And it says the second pillar will be a social health insurance, which will be fair and just. And that's why you keep on hearing nowadays people talking about a rate rather than a fixed amount of payment, so that it's equitable. And the third pillar, it says that we will deliver, we will have a fund for critical illness and emergency. And for a long time, that has been one of the biggest problems that we had. Emergency fund is said to be a right in the Constitution. The Health Act says the same, of 2017. There have been policies, but it has never been implemented. So for these now laws, so basically all they are doing is implementing
the manifesto.
So for me, I would say I would give it a tick up to this point where we are, that what was promised and what was through a consultative forum is being implemented step by step. For me, it's just to make sure the journey just continues. And that's why I was saying, for UHC, it's not something that you can say we have arrived. This is the final destination. It's something that you will keep on improving.
Going in the journey.
Continuously.
Right.
Because as it is now, even in the West, if you look at UK, NHS does not provide everything. There are certain things that are excluded. They will tell you this, we can't. This, no. This has a waiting period. This, so that it means resources are constrained, and you can't have unlimited access to the way you would want.
Geoffrey,
So in terms of a start, we are on the right.
we are on the right path.
Yes.
We are off to a good start.
We are off to a good start.
Okay.
And for the first time, a manifesto means something. At least.
What's on paper
Is at least being put
is
into practice.
coming into practice.
Yes.
Jeff, the conversation about UHC is not new.
Sure.
I mean, from the Kibaki days, there was a conversation about how can we have a wider, better, far-reaching access to healthcare. Into Uhuru 1 and into Uhuru 2, when UHC was one of the big 5. At that point, you were in NHIF, and NHIF was being said to be going to be the anchor for UHC. What you're seeing now that's being rolled out, is it the conversations that were happening within the boardroom of NHIF and within management of NHIF?
Sure. UHC, I think, began way back even in 73. Some changes to NHIF. I think that's when they brought in all the other people. Remember when NHIF began was selective to some group of communities. And these changes have been cumulative all along. But I think what we had then, we lacked the structure in terms of the law. Because the shape of NHIF then or now could not master the whole drive to attain UHC, because as we know, UHC encompasses more, not only the financing bit. When you come to curative aspect, there's more components to say that a country is towards the road to UHC or it's achieving UHC. So those discussions were there. We were trying to see what the law provided then and what can be done. But I think what we have now is more broadened and a better platform to want to say that now we are on the road to deliver UHC.
Is it a radical shift, though, from the NHIF that we knew?
Yes, in terms of the other components that have been brought in on board. As Dr. is saying, when you look at the critical illness aspect, the emergency aspect, and the promotive aspect of having community health workers, we had them long time before, but something broke along the way. I don't know what. Maybe Dr. can tell us. But without those
IMF
aspects,
happened.
yes, without those aspects on board, you cannot talk of even UHC if you're only talking on the curative and the financing bit of when you fall sick. So I see this is quite broad. It's quite good. It takes us to the journey where we should be.
Okay. One of those big issues being preventive care. And looking at the disease burden on the country today, it's interesting because we had a conversation towards that effect just, in the previous hour. So looking at UHC, medical practitioners around the country been calling on this aspect of preventive health. And one of the issues or one of the factors that prevents that, if we can use that, is the cost. So are we saying now that UHC, in the way in which it has been designed, is going to then bring about this element of making sure that preventive health is sought after and paid for because of this card, essentially, that we will have?
I would say so, because if you look at the current setup for CHPs, community health promoters, the first thing they will do is at the household level, and that's why it's called level 1. So they will be able to come to your household, do the necessary in terms of registering, take your blood pressure, look at whether you have medication. Are you going to the clinic? If you are pregnant, have you started your ANC or not yet? Then if you are diabetic, do you have medication? Are you compliant? Are you using your medication? If not, so the first thing that they will do is tell you now, connect you to your primary health care provider. That's level 2 and level 3. So one of the things I'm assuming the primary health care fund will do is pay for screening for certain things, whether it's cancer, so that when you reach a certain age, it's automatic that you need to be screened. And if you don't, then there are certain things that might be put in place to say that you have to do X, Y, Z. So that is the initial aspect. And my assumption is that that's what will be pushed in terms of incentivize. That's the word, that you will incentivize the providers to do preventive rather than the curative thing that we always do. And we already have guidelines on where screening should begin in terms of age-wise, in terms of demographic. And for me, that is one way to address it, in the preventive aspect, and pay for it. So that you, as a Kenyan, you don't have to worry, how am I going to pay for mammogram, for example? Because I saw earlier we were talking about breast cancer.
Yeah.
So how do you, if you have a history, how do you now again say, okay, your family history, then because you are likely to get it, how do we put you on that program? And for me, the other thing that will address that issue is the issue of the digital agency and this new superhighway for health information, where every facility will be able to access your patient data and see that you have a family history, you have reached the right age, you need to be screened. So those are the things that it's the doing is where we are moving to. Yes,
That's where
but in terms of structures, I think we have the base and the basics in place.
These basics that you say in place, what are they exactly?
The Act. So when you talk about tax funded, so it means your primary health care, including the community health, people is money that's appropriated by Treasury for service delivery. And it's for service delivery. So it's not money that's given to facilities to use it like a budget. So it's money follows service. You provide the service, then it's paid for. So if you look at the community health, they have already started working in some counties, and they are already sending the information
on the gadgets.
On the gadgets. So it means even now as we speak, at the headquarters, the government is able to see digitally on a dashboard where are the pregnant mothers, how many have started clinic, how many have not started. Then you can even do interventions and find out why or what are the obstacles of these mothers not going for those clinics. So you can be very specific and know it's in this constituency or sub-county or village that there are 10 pregnant mothers and the 10 haven't started clinic.
Yeah.
So you see, it's giving us real-time information. We don't have to wait for surveys that will be done 5 years or 10
Are we
years.
sure that this is happening? So we can be sure that we have people with backpacks
Yes.
going into villages.
Yes.
We could also say that maybe we are sure that for the first week or so, these people are actually keying in the data. Are we sure that they are constantly keying in the data? Number one. And number two, are we sure that this data is going to a central place and that there is somebody on the other end who is looking at this data? It could just be going there, but it just
Goes and sits there.
I think that will be answered best by the Ministry of Health. But what I know is they have one digital platform called ICHIS that they are all using. And
these
keying
gadgets
in.
have been linked to this
It
platform.
has that.
It has the capability.
It has the capability, and it also has the app. So they key in whenever they go to every household. And the way the structure of community health promoters works is every group have one supervisor, so that there is also somewhere else that they report
Some
to.
accountability.
Yes. So there is a chain of command. So even if you don't show up, there's a way that it can be seen by whoever is looking at it. Yes. And I'm sure they were not just meant to just go and carry the backpacks without providing data and without...
No,
That's
you're
why
sure.
I've told you. The idea is not to spend all that money so that people don't
Of
just
course
go
it
and collect.
isn't.
Actually, it could very well end up there. You see, if you do not have a support system that ensures that the data that's being collected can be actioned, then that is precisely what we will have. So, yes, we see people with backpacks. Yes, they are collecting data. I am assuming they have been trained in more ways than just to collect data.
Yes.
Okay? Now, having assumed that, I am also assuming that wherever that information goes, there are people who analyze it, and there are the people who move it forward so that it can be actioned. And I'm also assuming that we have health facilities to which these people can actually report to, and to where these services that we're speaking about will at some point be there to provide the service required if it doesn't exist already. Assuming.
Yes.
I think that's quite possible, because even during the pilots we did, the initial drive to UHC, we were picking data from Isiolo, it was Isiolo, Machakos, and Kisumu, and that data was being relayed to the ministry.
That was Nyeri as well.
Yes, so that's quite easy to do. And most of these primary health promoters are seasoned because they've been doing these things when the malaria drive comes. They've been doing it when the polio drive comes. They've been doing it. Only that it was a bit segmented. Now the idea is, I would believe, is to bring it holistic together and have it done in a more organized way. So I think collection of data has been there. What the drive should be is to have that data in a central data bank that now accessibility can be broader. Its use can be much broader.
That's it. To put it into proper use, that data needs somewhere where it sits, and there's somebody who is able to analyze the data, to break it down, and to pass on the information. To flag those things that you're saying. We have 10 pregnant women in a certain village who have not started going for their antenatal care. So why are they not going for antenatal care? Probably because the nearest health facility, there's been no medical practitioner there for the last 6 months. So where would they be going to? Those issues, the follow-up questions.
Yes.
But let's take a break. We'll continue this shortly. 8:30, Dr. Abdi Mohamed is the chairman of the Kenya Association of Private Hospitals. Geoffrey Mwangi is a health financing expert and former CEO of NHIF. We are talking about UHC. Are we off to a good start in the rollout of UHC? It was launched by President William Ruto last week on Friday. It's a week down the road. Where are we? What are we looking at? We'll be back shortly. Let's take a look at weather and traffic.
Spice.
Dr. Abdi Mohamed and Geoffrey Mwangi, who are in the studio. UHC launched last week. We're talking about the community health promoters already out there. They were flagged off earlier by the president still and says, go ye and start serving the people. And they were given the gadgets. And they're walking. Now you're saying, right, they're walking into the communities and they're starting to offer that service. There's a conversation that I'm not hearing. I'm hearing a conversation, and there's a bill on the facility improvement. Facility improvement. So let me start the question from a bit far off. Jeff, if you look at the balance, in fact, even you, Dr. Mohamed, how many, what's the percentage of healthcare provision that's given by public and private? What's the mix?
I would say almost 50-50. If not, if you combine private and mission, they can even push to 55-60.
So private and faith-based,
Private and faith-based, yes.
are more than public.
Yes.
Okay. Now, this community, the health
The
facility improvement fund,
yes,
is to go to the public.
So that's for the public. If you recall, before devolution, facilities used to keep the fund that they generate within the facility to improve on service delivery. Then when devolution came, that was removed. Some counties decided to bring that part back. And what they have done is around 26 or 25 counties have had FIF in one way or another, with different variations. So some would say 70% remains in the facility, 30 comes to the central. Some would say 60, some would say 80, some would say 90. So this now makes it all the 47 to have a uniform 100% retention at the facility. So the reason for the retention is that when you have budgetary allocation from the county, sometimes there are delays, but you will find a facility is not even able to buy water or detergents to clean the facility. Sometimes they run out of drugs. Maybe KEMSA was never paid by the county, and the money they have collected through service provision, whether it's through NHIF or whether it was cash people are paying, has gone to the central
to the county.
So then, so how do you now improve service delivery at the county facilities, public facilities, so that they can also compete with private facilities and mission facilities? Is by allowing them to have, to be able to buy things, to be able to improve on their service delivery, by not just waiting for the...
So they have cash.
So they have cash.
They have float.
So they have, other than the budget, they have extra money that they can now use to improve...
To meet their daily operational needs.
Operational needs.
Okay.
And luckily, in each of those facilities, there's a community representative that should be part of the board.
For accountability purposes.
For accountability purposes. Right. So for me, I think it's one thing that
it's a good
will help in
now
terms
my
of
question.
Improve. Yes.
Okay.
Yes.
45% of our facilities of healthcare is provided by the public health facilities.
Yes.
I am not hearing a conversation that is saying, as we roll out UHC, let us aim to increase public health facilities. Is there a conversation about not facility improvement, but facility establishment? So we have more health centers. With a growing population, are we saying that now it's easier, we are going to have those dispensaries and health centers being constructed closer to the people? Are we going to have level 3 facilities, new level 3 facilities coming up? Jeff?
First, I wanted to talk about the ring fencing of health funds. And this is a debate which has been there even longer, even before devolution, because like then in NHIF we used to look at how do we avoid this money which has been generated to drive health, not move out from that circle of healthcare. And this debate came strongly when we were doing capitation, because that model of payment allows the underwriter or the insurer to pass over the risk to the provider. But also, the insurer allows the provider to have the funds upfront even before he undertakes his commitments. But you would find if it is a private provider, he would pick the money and go build his flats. So you find the health money has moved out of that cycle. So I think that bill comes in handy to try and ring fence health funds, which is a key component. And I don't know how far it can be applied even to the private sector, other than only to the government. But coming to your question of health provision, government vis-a-vis private, I think government, to me, should only come in where the private has not gone into. What the government should do is what it's doing now, provide a mechanism of affordability of healthcare services whenever somebody seeks for them. That combination of we provide and private, if somebody can afford to pay for their health services, whether being provided by the private or mission, that should be the key thing.
Did private facilities not come in the first place because there was a gap in what public was supposed to have provided? So if we're saying that government comes to fill in what private has not taken care of, it seems a bit off to me. That if we look at health as one of the priorities that government then is supposed to provide for its citizens, what we are saying here essentially is that let the private people come and do it, and then where they cannot reach, then government will come and supplement. It should be the reverse.
I think, government provides social services to the people. And private players are there to invest, filling the gap of where maybe the government has not reached.
But not to take over the responsibility of government. Government has a responsibility
and in the
terms
health
of provision
sector,
of
it
health
seems
care.
that is exactly what has happened.
Absolutely.
Jeff, I don't know, because I know there are countries
let's start
where...
with those basic, okay?
Where
the government is recruiting community health promoters. Right? And the community health promoters should be linked to a facility. Right. Should this facility be private or should it be public? Let's start with that.
It's any facility. And that's why you need to go back. I will tell you again, look at the manifesto, and it's very categorical on when it comes to service delivery. One of the reasons why UHC failed the experiment, the 4 counties, is the service was only delivered by the public facilities. And that did not work.
Of course, because government was not building. Go on.
Let me finish. So that, what you need to understand is what matters is, it doesn't matter who is providing the service. What matters is the service being provided affordable, quality assured, and there is a financing mechanism. If you look at Japan, for example, which has one of the best UHCs, majority, almost I would say 90% of services are delivered by the private sector. And what he said was actually correct. It's where private sector feels that it's not viable is where government invests in Japan. Look at their healthcare system. If you go to Germany, the same. It's more of private sector that provides. Yes.
Why giving examples of first world countries when we know full well we're a third world banana republic, and everything that you're referring to is so far-fetched? We might as well have health facilities on the moon. It's for me, it was the idea that we keep on saying, like the private sector shouldn't provide these services.
No.
So for me, what I look at is what matters at the end of the day to the common man, you and me and everybody else, is am I getting services? Number one, quality, and is it affordable?
But look at what has happened.
So if I get those 3 things, then I would say I'm covered.
So can
I don't
ask
have
a
to worry
question
about.
then, Dr.
Yes.
If that was the case,
Yes.
wouldn't we then see that everybody then today in the country would be accessing private healthcare without a problem? But what do we see is that most people are flocking for public health because it is cheaper. Or is what you're saying now, with the rollout of UHC, what we will see is that it doesn't matter where you go. You go to a private facility or you go to a public facility, you'll then be able to use your coverage and it wouldn't matter. Because right now that is not the case.
Yes. And what you need to keep in mind again is what extra things do you want? For example, if you go to a private facility and then you ask for an extra sitting room, or you ask for an extra toilet and what within your... So that's the part where private comes into some places. That there are people who want extra things, which are more... that cannot be... Yeah, they are not basic.
Yes.
Oh, okay.
So what... Now with this UHC, you will be able to get the services that you need based on, irrespective of who is going to provide the services, whether it's mission, whether it's public or private. Now to come to your question, the idea of who is going to build, now that's where now counties come in. That's now where CDF comes in. That's where now the different players come in. On how to build new facilities. So the question is, are we suffering from service delivery unavailability, or is our problem the financing mechanism? That is our problem. Are there empty beds?
My uninformed guess would be it's both.
It's both.
There are very many cases, very many places.
Yes.
If you went to all these Mukurus,
Yes.
Kwanjenga, Koruben, and you will find health facilities.
Yes.
Okay? But you will find a Kador somewhere and it's written hospital. You don't know the quality of it all. Now, has there been a deliberate plan to make sure that the people of Mukuru can access quality health facilities? Has there been a deliberate conversation that makes sure that until COVID and President Uhuru and General Badi did that thing with building new facilities, there was no establishment of new health facilities in Nairobi. It was all going private, and then look at the quantum and also the quality that we were getting. So I would say it's both.
It's both.
There are very many villages that you will go to that do not have a dispensary near them. It used to be there when a location was the size of a district, and that was the location dispensary. There hasn't been any that has been constructed.
Now do I tell you one thing?
Tell me.
I inspected those facilities.
Which ones?
The one NMS built. And I can show you after this photo evidence that after they were launched, majority of them were empty.
Of course.
They had people, workers, but no patients.
Why?
Because there was no the required
because they
drugs.
don't get the commodities.
Commodities.
Yes.
So now you understand where now the issue of FIF comes in.
And that's why I was talking about from the very beginning. If there's a deliberate plan to have, let's look, the health facilities that we have, are they commensurate with the population that we have? Per area, per region, per all. Now let's have the other conversation. As you're financing this, are you giving them the facilities, the necessary commodities, plus healthcare workers, plus everything, plus equipment?
And that's when we will know, once these laws and the regulations and everything come into effect, that's the time we will realize what are the issues. For now, it's hypothetical that the demand will outstrip all the available resources in terms of service delivery. That's your hypothesis. And that's why you are saying we go to brick and mortar. But if you talk to healthcare workers...
It's not hypothesis.
No. If you go to healthcare workers...
The fact that we have public health facilities that are congested,
yes,
that people are sharing beds...
It's a fact.
Is a fact. And it tells you something.
And that's why they drive to UHC.
And the reason why we see people flocking to the PGHs is because we lack level 3, level 2s.
And that's why now you have a mechanism where you have a primary health care fund. And actually that's the whole architect of these 3 funds. So what does it do? It tells you stay within your primary health care facilities.
That's the basis of my question.
And then you are referred
That
upwards.
is the basis of my question.
Yes.
You got it. Now let me come to you. So, because we are saying there is a taxpayer-funded primary healthcare provision.
Yes.
This should go with building facilities so that you make it. What is the cost for health? It includes transport. It includes time.
True.
If you're telling somebody in Kimana or Loitoktok, they're coming from Loriga, they're coming from Darara, they're all coming to Kimana, you are messing them up. But put it closer.
Yeah, and that's why UHC, because UHC, what does it stand for? It's access, not only access, but to quality. Not only quality, but as you can afford to pay for it. And I think these gaps now will start be filled in as we roll out the journey towards UHC, because that's where you find those who not have access must be allowed to have access, whether it means building a new facility where the people, the distance is far. And some of these community health workers are to fill up those gaps and report that, you see, what is happening in this area. For one to access a healthcare facility, they need to walk 20 kilometers.
There's a concept that has come in over time to help solve what you've just said. It's called task shifting. So that you utilize what you have to ensure you provide as much service as possible. The example you gave of Japan is true up to this point. Remember, in Japan, health facilities, whether they're private or not, are non-profit. That's the rule. They're non-profit. Even what you call a private health, it's non-profit. But it is shared. Depending on the family income, you contribute. You know this 2.7% we're talking about, you contribute 10, 20 to 30%. Then the balance the government supports. Japan have a saving culture like probably no other nation on this planet. So their government, when we talk about borrowing, they don't tend to borrow elsewhere. They just borrow from their own facilities because they have that culture. They have a lot of money. Now, it's a model which works. Now, if we're saying that 2.7% is to go towards what we're saying, I can see a glimmer of hope that this will actually work But then I would also say that 2.7% may not be enough if we are to actually provide what we are hoping to envision. Because of the workforce we have in this country, how many actually earn a regular income from which that amount can actually be deducted to provide these services that we need and we must actually have? You see, I asked about the training of the community health promoters, and I asked about the other tasks that they have. There are very many medical conditions that do not need hospitalization, neither do they need someone to actually even go to a health facility. These are things that can actually be managed. They can be diagnosed syndromically and they can be managed. You are a medical doctor, you know exactly what I'm saying. Now, I am saying it is an ambitious project and there are many things that need to be done. And that we have started in itself is a good thing. But even as we continue, are we saying that the building blocks to ensuring that the UHC works are actually being monitored and ensured that they are put in place?
I would say yes, and let me explain maybe the way this thing is supposed to work from my understanding. So you have the community health promoter, and then you have the primary health care fund, which is tax funded. So the idea of the primary health care fund is to align you to a network. So there are around 315 primary health care networks. What does that mean? It's a geographical area. One network is a geographical area, maybe sub-county or something like that. So you, who is a resident in that area, will only go to these facilities within your network, irrespective of who the facility owner is.
Mm-hmm.
Whether it's public, private, or mission, it doesn't matter. So what does that do? You can't jump and go to Kenyatta National Hospital.
Mm-hmm.
You can only go to Kenyatta National Hospital or to even Mbagathi after you have been referred by your primary health care provider. So that you are referred to a facility, a higher level facility because of your condition.
Yeah.
And that's now where your social health insurance kicks in, the one you have contributed. In whatever amount, whether it's 2.7 or 2.75%, however it will be calculated, you utilize that in level 4, 5, and 6 for all your secondary care or tertiary care that you need. So this is now where we will realize in this network, there are only 3 primary healthcare facilities. So the population, it's not enough to cater for. And now that gap that you're talking about will come in and say, okay, if in this primary healthcare network, this one doesn't have enough facilities, how do we now improve on the number of facilities in that space?
Is that in any of these laws?
Yes. That's why the
say?
primary healthcare bill,
So what does it say?
it's
It shall build.
no. You see,
That's the point I'm raising. So once we start rolling this thing out, and our basis is bottom up
Yes.
in UHC,
Yes.
we are starting from home
Yes.
to network.
Yes.
Network
Primary healthcare
going up.
network. Then you
Going
go to
up.
secondary,
So if
tertiary
this
care.
bottom,
Yes.
if we are not talking about this, once we realize, because the first thing we're going to do is realize that this population is not being adequately served by the facilities that it has.
Yes.
Is anything telling us what we're going to do? Because if there's nothing that telling us what we're going to, it's going to take us another 5 years to come up with a new bill that says, okay, allocate budget, start building health facilities. That's the fear I'm seeing. If we have not said that within the first year we are going to be able to realize the strength of our network, and this is what we are going to do to fill the gaps in our networks, what are we saying?
So you want a bill that says we'll build hospitals.
Well, just to
I
build
want a
them.
bill that says the first thing that we're going to do is have this network,
Yes.
and we will
No, that one is already there. The network is already there.
and we will audit
the referral.
we will audit the
system is
quality
there.
of this network.
Yes.
And if we find that the quality is wanting, this is what we shall do.
Yes.
Either bring Dr. Mohamed and tell you, bring your hospitals, bring people to build, or we put in money to build facilities, something. Without that question being answered, once we realize, then what? You see, the thing is, when these guys carrying their backpack say people are not going to hospital because there is no hospital nearby,
And I think at that point, having the county governments and the national government, I think that's a gap that can be filled. But you realize that there has to be a beginning.
Not only county and national, it can also be filled by the church. And
or even the private sector.
Okay.
So we are hoping that something will happen.
No. It's not hope.
Let's
When
take
there
a
is a
break.
demand,
Let's do
for
news.
sure.
Let's do the news. We did not start by saying, can people start identifying healthcare promoters in there? We said, let us recruit healthcare promoters. Let us map them to a network, and it is a geographical 10-kilometer blah, blah, blah. Then we should also have said, but let's continue this conversation shortly. Geoffrey Mwangi and Dr. Abdi Mohamed are here. We're having a conversation about universal health coverage. Are we off to a good start? What are we doing? 9 a.m. news time.
This is the Situation Room, the only way to start your day.